talking about the rest of the oral squamous cell carcinoma. Now, let's talk about the histopathological features. Now, basically, the oral squamous cell carcinoma arises from dysplastic epithelial cells. These dysplastic epithelial cells invade and destroy the normal tissue and eventually extend deep into the connective tissue. As we can see in this slide, we can appreciate that there are presence of invading islands of squamous epithelial cells. Now, let's talk about the cellular features. There's going to be cellular pleomorphism. Cellular pleomorphism is the variation in the size and shape of the cell. Nuclear hyperchromatism. This is basically darkly stained nuclei, and there's also going to be presence of prominent nuclei. So, very darkly stained and prominent looking nuclei. A picture here shows us this. Now, we will also see some increased nuclear to cytoplasmic ratio, meaning the nucleus size is bigger as compared to the cytoplasm. And we're also going to be looking at some increase and abnormal mitosis. There is also going to be presence of reverse polarity. The normal polarity for the basal cells means that the nucleus is present just adjacent to the basement membrane. Whereas in reverse polarity, it's going to go opposite to the other end of away from the basement membrane. Basal cell hyperplasia. The basal layer just next to the basement membrane is going to increase in number. There's going to be presence of drop-shaped retepegs. The drop-shaped retepegs basically show the invasion of the squamous epithelium into the connective tissue. There's also going to be loss of cellular adhesion and cohesion, meaning the cells are going to lose their ability to stick to each other. And there's also going to be presence of the keratin pearls. Now, what are keratin pearls? Keratin pearls are a whorl-shaped accumulation of keratin, which is produced by the malignant cells. This occurs due to lack of cohesion among the epithelial cells. Now, this occurs basically due to the malignant changes. Eventually, the cells, they get arranged in a concentric manner. A picture here shows us the keratin pearls. As we can see that they are circular in nature and the keratin is laid down in a concentric manner. Now, to remember all these cellular features, there is a simple mnemonic. Carrie loves pink bird. So guys, just remember this mnemonic and you'll be able to memorize all these features. Now we're going to see how the squamous cell carcinoma is graded. Now, basically, grading is based on the degree of resemblance to the normal squamous epithelium and also to the amount of the keratin production. It is divided into 3 grades, grade 1, 2, and 3. Grade 1 or low grade is a well-differentiated carcinoma. This means that it closely resembles the original tissue, meaning the squamous epithelium. So it is going to be difficult to identify if this is a normal epithelium or if neoplastic changes have already occurred. This kind of tumor metastasizes very slowly. The second type is the moderately differentiated or the grade 2 type of tumor. In this, there is going to be less amount of keratin pearls and the dysplasia is going to be much more prominent as compared to the grade 1. And the last one is the poorly differentiated, the grade 3 or high grade tumor. In this, there is going to be high levels of keratin pearls and there's also going to be presence of perineural invasion, meaning that the high grade type of the squamous cell carcinoma is not going to resemble its original squamous epithelium. So it is going to be well differentiated, meaning it's going to be more dangerous as compared to the low grade kind. Now the TNM staging. So basically the TNM staging is done to assess the extent and severity of the cancer. T stands for tumor size, N is the nodes, and M is the metastasis. The tumor size. T0, 1, 2, 3, and 4. T0 means that there is going to be no evidence or presence of a tumor. T1 shows that the tumor size is 2 centimeters or less than 2 centimeters. T2 is 2 to 4 centimeters. 3 is more than 4 centimeters, whereas T4 is more than 4 centimeters, plus it's going to involve some of the surrounding structures, like the bone and the nerve. Now the N0, 1, 2, and 3. N0 means that there is no regional lymph node metastasis. N1 means that a single ipsilateral node is involved, and it may be 3 centimeter or less in diameter, meaning one-sided node is involved. N2 means single ipsilateral or bilateral node 3 to 6 centimeters in diameter, and node 3 is more than 6 centimeters in diameter. Now M, which stands for metastasis. So simply if it is MO, it means that there is no metastasis. If there is M1, this means that the tumor has metastatized. In some cases, the tumor does metastatize and spread to the surrounding lymph nodes. Let's look at some of the lymph nodes. Over here, we have the submandibular lymph node, and just next to it is the submental. And above it, just next to the parotid gland, we have the parotid lymph nodes. The tonsillar lymph nodes are also present, postauricular and preauricular, superficial cervical, and the deep cervical. These are the lymph nodes that the squamous cell carcinoma may spread to. Now, if the lymph nodes are involved, they usually turn stony hard and they become bigger in size, and sometimes they may even be painful. Now, the metastasis of the oral squamous cell carcinoma occurs through the lymphatics. Just like we discussed before, it spreads to the lymph nodes, and through the lymph, it spreads to the rest of the body. In most of the cases, if the oral squamous cell carcinoma involves the floor of the mouth, it usually spreads to the submental lymph nodes, whereas if it is present at the posterior region in the mouth, it usually travels to the jugulo-digastric lymph nodes. Now, it may also involve other organs like the lungs, the liver, and the bones. Now, let's talk about some of the investigations which are done to diagnose the squamous cell carcinoma. First of all, we're going to take a detailed history of the patient and carry out a clinical examination. Now, the clinical examination needs to be intraoral and extraoral. In intraoral, we need to check non-healing ulcers, leukoplakia, or any masses which may be present. And for extraoral, we're going to check out the lymph nodes. We're also going to see if there is any swelling present. Now, if there is a swelling, we're going to check its site, consistency, how big it is, and the color. And we're going to ask the patient if it is painful or not. Dental radiographs. Dental radiographs are simple and they're cost effective. They can be used to plan the resection of the tumor and to evaluate the remaining dentition. And we can also check the bone involvement using these radiographs. A CT scan or MRI scan is also advised if metastasis is suspected. MRI is going to outline the soft tissue lesions within the tongue and the floor of the mouth. We can also use it to determine if there is any neural involvement or intracranial extension of the tumor. Now, let's discuss the treatment options for the squamous cell carcinoma. The basic and the first line therapy for the treatment is surgery. It is very important that we excise the carcinoma, and it is important that we keep a wide margin, ideally of 1 centimeter or even more, around the lesion. This is going to make sure that none of the neoplastic cells remain, so that it may not reoccur. After the excision, biopsy is to be done and the level of dysplasia is evaluated. Post-operative radiotherapy is recommended. Now let's talk about radiotherapy. Radiotherapy is basically X-rays, gamma X-rays, or radioactive isotopes, and it is usually indicated if there are good resection margins, if the tumor is high grade, or if there is perineural invasion. Intensity modulated radiation therapy, IMRT. This targets the treatment area and it minimizes the damage to the surrounding tissues. There is also brachytherapy. In brachytherapy, radioactive seeds are placed at the site of the tumor and it targets specific cells. So it may also be combined with IMRT for some additional dose. Now, as important as radiotherapy is following the surgery, it has some adverse effects. They include xerostomia, which is followed by dental caries. There is also loss of taste, trismus, and osteoradionecrosis may also occur. So, osteoradionecrosis is the bone necrosis which occurs due to the radiation therapy. If regional metastasis is suspected, the surgeon carries out neck dissection. Now, there are three kinds of neck dissections. There is the modified neck dissection, in which all of the lymphatics are removed along with the internal jugular vein, sternocleidomastoid muscle, and the accessory nerve. Then there is the modified radical neck dissection. In this, all the non-lymphatic structures, meaning all the structures other than the lymphatics, are saved while the lymphatics are removed. In the selective neck dissection, only the cervical lymph nodes are removed. Prognosis. There is a 5-year survival rate for the oral squamous cell carcinoma. Some factors affect this prognosis. Early diagnosis or poorly differentiated squamous cell carcinoma. It is important that a dentist is able to diagnose the squamous cell carcinoma at an early stage so it can be diagnosed and treated as early as possible. If it is poorly differentiated, it means that it is going to be a high-grade carcinoma, meaning more aggressive. Blood supply. If the blood supply is good, which usually is the case in the floor of the mouth, then the prognosis is not going to be as good as compared to other locations, because there is increased vascularity present in the floor of the mouth. Extracapsular spread, meaning metastasis, and some lifestyle habits like tobacco and alcohol use, nutritional deficiencies, some cultural practices, and the presence of comorbid conditions also contributes to the development and worsening of the prognosis of the oral squamous cell carcinoma. So guys, this was everything about the squamous cell carcinoma. I hope you learned and enjoyed.